everybody. Susan Clinton here with my co-host Carolyn Van Dicken, and this is the Genius Project. We are actually at Project 9. This is 2021, and our goal this year was to change the project just a little bit, as you all know, and talk to clinicians about the question, how did they do it? And we are so excited today to have Dr. Sinead Dufour with us. She is a professor at McMasters University and is also a clinician. And Dr. Dufour, if you don't mind introducing yourself and letting us know who you are, where you're working, and then we want to talk about your journey of your clinical and academic experience in moving into the biopsychosocial realm.
Okay, perfect. Thanks, Susan. And thanks, Carolyn, for inviting me to come on. So yeah, I am an academic clinician. So that really means that I share my time between McMaster University. I contribute through research and teaching in the School of Medicine and the School of Rehabilitation Science. And then the other part of my time, I do clinical work. So I'm the director of pelvic health at really now a family of perinatal care centers called The World of My Baby, the Womb. So my clinical work really is more focused in that aspect of women's health. But in addition to these things, you know, I have found myself involved in committee work. I do quite a bit of work with the Society of Obstetricians and Gynecologists of Canada. And I sit on some other committees for other organizations. I teach postgraduate courses for healthcare professionals with Reframe Rehab, pelvic health solutions, and bioformations. And I'm a busy mom of two wonderful children, and yeah, balancing it all, but really do kind of spend my time half in academia and then half in the clinical world.
Wow, just listening to you, Sinead, just makes me wonder how you do it all. And Susan and I are kind of through the kids stage and kind of more into, well, I just became a grandma, of course. And so, you know, it's a whole different phase, but we remember how busy it is with young kids. So our hats are off to you as you try and juggle all of that. I have had the pleasure of knowing you for quite a few years now, maybe a decade or so, Sinead, and really have enjoyed working alongside you, both as an instructor, but also as a researcher and as a clinician. And I've learned a ton from you. I wonder if you could just take us through a bit of your journey around kind of those early clinical days and how you actually started to create this broader perspective and practice that I know that you are well entrenched in at this point from a biopsychosocial or whole person perspective.
Yeah, absolutely. So, I mean, I finished PT school and like many of us kind of jumped right into private practice, you know, mostly doing orthopedics. I went through and I got sort of my first few manual therapy levels. So in Canada, that was on the system where you could get like a Part A and then a Part B was your full certification. So I went right through. I had my Part A's. I did my acupuncture, and I really was very, very busy into kind of more standard private orthopedic practice. And really, I didn't initially have intentions necessarily of jumping in and doing further doctoral work or in the academic side. I really kind of jumped in full on into clinical work and was so excited to kind of start being a physiotherapist. But what I noticed really quickly was, you know, just patterns in our healthcare system that really felt like things were quite backwards. So I often was, you know, feeling like I was in a situation where once again, I had an individual coming to see me and, you know, maybe it was, you know, an ongoing pain situation that kind of finally got them into the door to see a physio in a private clinical setting. But really, when you listened to their journey, I mean, it was just so evident that if like the right care at the right time, years ahead had have happened, we probably wouldn't have all these other secondary issues. And I felt like I was seeing that pattern over and over again. It was quite frustrating, to be honest with you. I really felt like with my skill set, there was so much I could do if it was more upstream. And so what was interesting is just kind of timing, and timing kind of seems to be everything. But it was just after I'd been practicing for about a year and a half that in Ontario, in Canada, where I'm situated, the Family Health Team Initiative was started. And so this was really an effort with the government to actually try to completely reorganize primary health care, right? First line care. And the idea was around not having this gatekeeper, this one doctor kind of funneling through, but actually having a whole team of providers at the front end who all had a diverse skill set, really to speak to that notion to get to the right care to the right person at the right time upstream. And so, of course, this really resonated with me. And I thought, well, that makes perfect sense. And physiotherapists were very much supposed to be one of the professionals at the table on those teams initially. And at the last minute, actually, the government blocked them out. And so for me, having kind of following this movement and being really excited about it, seeing it was such an important way forward for health, that's actually what motivated me to go back and look at it and study it. Because, you know, with the research I had done, it was very evident that the number one reason why people were coming to primary care to their physician was because of a pain concern, a chronic musculoskeletal issue, an arthritis condition, like really things that were very much key to what physiotherapists could assist with in the healthcare system. So that's really what got me into kind of going back and pursuing doctoral work. And then I suppose it was really through then collecting my data, doing those studies, and then going on to postdoctoral work that it was really evident to me that the whole kind of health promotion, healthy living side of things still really isn't getting done. So in my postdoctoral work, which data for that, I collected years and years and years after the Family Health Team Initiative started. And I had kind of assumed I would see positive trends in terms of things being handled more from, you know, a biopsychosocial perspective. But actually, one of the key findings that came out of my postdoctoral work was this major miss on the social dimensions of health that came through over and over. So I suppose I just always kind of carried that with me and kind of integrated it into my practice as I went on. And I suppose that probably naturally guided me to learn more actually about healthy living. And, you know, I ended up getting quite a bit of education in functional medicine, actually, which really does kind of harness more of a root cause, holistic approach to really just get all the biological systems functioning in a healthy way, but acknowledges that our emotions, our spirit, our environment, all of those things modulate the systems. And I think I was just drawn to that approach because of all the groundwork that had been laid in my career thus far.
Amazing. I wonder if you could give us some insight. And I remember very much that family health team. I put in a proposal with my very diverse and strong family health team to be part of that initial effort. And I can remember my disappointment as well. I didn't take it in the quite the same direction that you did, and it didn't spur me on to do my PhD. But I'm curious as to what you discovered in that process around why the government actually sort of cut physiotherapists out of that environment early on. Did you discover anything through your research in that piece?
Yeah, so what was interesting is, you know, one of the key things that ended up coming out, because we did a series of different projects within a whole frame of a research program, really, and some of it was qualitative, so it was interviewing, you know, representatives from the Ministry of Health and, you know, other kind of administrators, as well as sort of key clinicians. And one of the things that came out actually was that at the same time that the family health team started, there was actually a delisting of some of the OHIP physio clinics. And that very same year in 2005. And so I guess more from a political perspective, the ministry was having a hard time justifying taking money out of the public purse from physio on one side, but then dumping it into the public purse on another side. So they made the decision to kind of move forward with dietitians, social workers, and pharmacists as the first 3 pilot members of the teams. And they just said that they would have physiotherapists wait. So, I mean, I think some of it was political initially. But even as, you know, we moved through and finally did get physios approved on the team several years later, what we discovered was actually was the profession of physios themselves, in a way, that really slowed the integration process down. Because really what was critical for us to enact our skill set and our knowledge base within the context of these primary healthcare teams, it meant we had to do things a little bit differently. You know, we couldn't sort of run our standard kind of orthopedic style practice out of a family health team where we're wanting to see people 3 times a week and use modalities. And we had to really flip things on our head and function much more like an expert in, you know, musculoskeletal health, in pain, in coaching around health promotion, and really be able to help people navigate the system so they only need to kind of be interfacing with you in the family health team, you know, once every 4 to 6 weeks. So it was a very different way that we really would need to enact our skill set, which certainly is possible. And certainly all the physicians and nurse practitioners who were interviewed as part of this work were desperate to want physios on board, but it was really physios themselves, actually as a group, couldn't really figure out how to enact their skill set outside of this tiny box that they had been used to. And so those were a few interesting things that came through, which I have to say, I still see that sentiment repeat itself over and over with our profession. You know, and it's quite frustrating, to be honest with you.
Absolutely. Susan, do you have a comment from sort of the American side of things with regards to what Sinead's talked about?
I find this story fascinating because I know on the American side there, it's not as wide of a push. There is a small segment that is working towards getting, you know, orthopedically trained physical therapists into the ER. You know, to be able to triage and see, you know, musculoskeletal problems as they come into the ER. And it is a very different way of working. And in fact, the University of Pittsburgh has a course on trying to help PTs learn how to interface with that system and what it means to be, you know, working in the emergency room team versus, as you were saying, Sinead, you know, seeing their patients 3 times a week, doing this, you know, the progressive exercises, things like that. But instead really having to get down to what happened, when did it happen, what's going on, what do you need to be able to do, and how can we get you to do that, you know, with you know, and to remove the fear and, you know, the idea of damage or harm once we know that there wasn't, you know, that the PT could come in and really start to work along those lines, like you said, a bit more upstream. You know, when we had President Obama in office, there was thoughts about what they called medical, I don't remember the exact word, I want to say medical house, but it sounds very much like what you're talking about, you know, just first line, you know, ways for people to come in, and as they would come in, they would either see the nurse practitioner, they would see the physiotherapist, if they were coming, like back pain would be shuffled straight ahead, like the first person that they would, you know, see would be the physiotherapist. You know, if they were coming in with a, you know, cold and sinusitis, you know, maybe the nurse practitioner versus, you know, so there, you know, then there's a few of those around the country. There are not a lot of them. We'd like to see a lot more of that type of care, and some of the different big payer sources in the United States have kind of initiated some of that. But again, physical therapy isn't really a big part of it. It's always still secondary. Like, okay, once we've given you medication and told you to rest, like, you know, or booted a sprained ankle, like, don't even get me started there. And, you know, then maybe 4 weeks later, we'll send you to the physical therapist or to physical therapy or
Yeah, exactly. So those are actually 2 kind of key themes that came out of the research in terms of what physicians and nurse practitioners, who were considered like the core family health team members, sort of acknowledged. They said, we really see a fit and a need for physios functioning in very much an MSK expert method for acute care, but we also see a huge need for them supporting us, supporting our programming for chronic conditions and chronic pain. And so, you know, it really is almost more that side that I have seen such a variability in terms of how physiotherapists are in these teams enacting their practice. So, I mean, there are some physios in these teams who have done great work developing self-management support group programs that meet once a week that they're doing. In fact, Jordan Miller, who used to be on faculty with me at McMaster University, his research is all in pain science, but as a physio, he worked out of, a community healthcare center, one of these team settings. And so some of his research really was kind of integrating this type of method of how physios should kind of really evolve how they practice, doing groups, doing health coaching, integrating this in, not feeling like they need to do modalities and this other realm of care, which has a place, but certainly that's not the way things would fit into like primary care. So I think we're just slow, like it's slow to come. It's coming. We can see certainly in our curriculum at McMaster, we completely revamped the curriculum 2 years ago. Literally completely took away, no more teaching orthopedics and then neuro and then cardio resp and then like an integration year. We don't do that at all. It is completely integrated from the first day they come, which is great. And in fact, the first problem that they have at Mac, of course, everything is problem-based learning, is actually you're working on a family health team and you have an individual come in and actually it's all around health promotion. So it's great that it's coming, but this is new. And I don't even think any other Canadian university has changed their curriculum like this. So I think it is going to be slow, but it is coming.
That's a really hopeful thing, I think, to kind of latch onto there, which is great. I wonder as well I'd love to get your thoughts on how do we shift our profession, because I think it has to start in academia, but then go all the way down the line from being kind of a fixing model of care to, as you say, a health promotion or a lifestyle, a wellness sort of model of care, right? Where we trust that the body actually does repair itself. And that when we get into trouble, it's because we're scared, we're distressed about the problem that we have, or that maybe we're weak, we've deconditioned, or we're tight. But those are fairly straightforward sort of concepts to kind of deal with in physiotherapy. But we really are kind of honed in on the minutia of fixing problems that I think is maybe keeping us held in this biomechanical or biomedical model. Any thoughts on that?
Yeah, I mean, I would agree with you 100%. Two things that come to mind that I think could potentially really help pave us to a more evolved way of enacting our practice, which really is going to better meet the current epidemiological needs, right? Which really is lifestyle conditions. So there's two things. It's really how physiotherapists have led the charge when it comes to pain science, pain neuroscience education. That has really helped us shift our thinking to thinking about more psychologically informed care, trauma-informed care. If we really are caring that way, it means we have to understand the cognitive side of things. We have to understand, right? So I think that has been an important, I guess you could say, development in our profession, because really, I mean, it is physiotherapists around the world who have led the charge in this. And I think that is one key piece that can help. I think another key piece is what's just happened with COVID. And it has forced us to pivot and shift to virtual care. And so this has really helped many of us to challenge our own beliefs around, do we need to be in there with our hands on? I mean, when I am with my patients, yes, like I do love to be hands-on, right? And I think there is another layer of magic and input into the system that can happen with that, hands down. But is it really the primary, piece to our intervention and to creating health? No, our data is pretty clear that the answer is no, right? And that there's so much that actually we can do without that. But I think we almost have needed to be forced to develop our own confidence and conviction that we can do so much without that. And so being forced to do virtual care through the COVID pandemic, I think is a potential opportunity for our profession to embrace that and to really start to exercise our muscles around, becoming better health coaches, So I think those two pieces, pain neuroscience, evolution, and really if we think of pain neuroscience education, the literature is quite clear when we're trying to do didactic education about what neurons do, etc. We see that actually it doesn't work as well as we thought. But when we are integrating it sort of in the format of like a counseling and it's personalized to the individual, and it really isn't a didactic education about the nervous system and the brain creating pain, right? Like when we see it so powerful, and I think the research will start to show that. So I'd say these are two key opportunities for our profession that it is nice to see many embracing. But at the same point in time, I mean, there was just a paper published about a month ago indicating that physios really believe that, virtual care isn't good enough. It isn't good enough care. So there still are strong beliefs around that. And I'm not really sure how else to get around it other than, those of us who are transformed our practice and are actually seeing better outcomes to be talking about it, by really making sure that the research in support of these models of care is actually being translated down to those working at the front line. So those would be some of the thoughts that come through.
And I think those are amazing thoughts, especially around the shift in pain science education to pain science, like you said, counseling, individualizing the approach. Tell me your story. Here's what's happened. Let's talk about how this has, affected your life and what we can do to begin to start to change that and get you doing some things that you really want to do again. But the virtual care is the perfect platform for that. And it has caused a lot of people to shift. I do think in the United States as well, there's something that came out from the APTA. I just basically skimmed it on my email, but the gist was, is telehealth here to stay? And I was like, what? I would hope so. I mean, we're able to reach populations that we weren't able to reach before. Not everybody can come in. I know that, you work with the world of my baby and that population. I can tell you in our practice, new mothers are thrilled to be able to reach over and turn on their computer and talk to us and not have to pack everything up and get it in a car and come and see. And it's removed barriers. Plus, again, we're right there with them in their home. Show me, tell me, let's see it. Let's problem solve right now here and but it is different. And I think physios are, I don't know if I want to use the word afraid, but I think they identify so much with, I put my hands on. And if I can't put my hands on, this isn't physical therapy.
Right. And I'm going to play devil's advocate because I would say that from all my colleagues that I speak to, the majority of them, I don't think the pandemic was long enough, Sinead. I think that the majority of them have gone back to in-person care with completely letting go of the virtual piece. In our practice, we have made a clear decision to do every assessment virtually, so that we start to show patients right from the beginning that a lot can be accomplished through a virtual session. And then we try and encourage having, occasional virtual sessions. It allows people when they're sick, or as Susan says, life's overwhelming and you can't pack up and come to the clinic, we can pivot and go right to virtual care because they had that experience from the beginning. But I would say that that's now become unusual again in PT practice, and people have kind of left virtual care behind again. So what would you say to that group to really kind of, it's still fresh in all of our minds, it's still here. Why should we pick that up again?
Yeah, I think that's a great point, because you're right. I mean, we can become a bit insular. And so, of course, I'm thinking, because we use a model similar to what you do, Carolyn,
right. Yeah.
I'm assuming that that's what most people do. But you're right. There probably are many that just revert back to their comfort zone. And I guess I would just say, I do think that is the wrong decision, and not just the wrong decision because, we could end up in a situation with a different virus and something happening again, and then you're just not prepared, but that is one very kind of clear, concrete reason. But I would say that unless, experiencing is believing, right? And so this is something oftentimes we are working with our patients with, so they can experience moving in a different way and see, oh, well, it didn't hurt that time. So it's not like I just strengthened my body within 5 minutes. So maybe there is something to the conversation we had about my nervous system, and right. But sometimes they need to experience it to believe it. And I think professionals are the same. I think you need to experience this new model, experience success with it to be convinced. And you're not going to have that opportunity if you don't even try. So, so how we have it set up at our clinic is we have it set up as an option for your full hour assessment virtually, or an option to split it into what we call part A, part B. And, but it isn't an option to just come in person. That's not an option. So you have to. And what we've been finding with our physios who have been less convinced, I think, and have maybe felt like they didn't quite have the confidence or the conviction for this model, is they themselves have come back and said, wow, I do that first half virtually, and I'm really almost kind of not convinced it's doing much, and kind of anxious just for the second half to kind of do like the real part. And every single time when I meet the person the next week, they say, wow, it was like, I'm already feeling like 50% better from that call. And so I think that's been really powerful, because that speaks more volumes than me telling them about the science and what works for me. And they have their own lived experience. So I guess that would maybe be my advice, for all clinicians to say, try it, give it a try. You will be so surprised how effective it is, right? It really is so powerful. I mean, the clinical guidelines, because there's a number of them that have come up, and one specifically for urogynecology, which as a pelvic physio, I'm, following, and has come up indicating like we have really good data to support how effective telehealth is. And I mean, this is even when we're thinking we have to like internally check the pelvic floor and we have to all do this to provide good care. It's not to say that can you get more complete and maybe, slightly enhanced care if you have that assessment bit? Sure, I'm sure you can. But it's to actually highlight to us, we don't always need that. There's so much we can do without it. And I think if you don't experience it, you don't prove it to yourself, you're probably always going to revert back to your old beliefs and your old habits.
Yeah.
Yeah, I think that that's really true. I know that from my perspective, I started when telehealth and the pandemic, we were still seeing some clients in the clinic, but not all. But I was doing all of my assessments, every single one of them, that, my first visits, all on virtual. And as we were seeing more patients in the clinic, I just still said that the first visit we do by Zoom, on our telehealth platform. And my story to them in the beginning was because we can see each other without masks on, and we can really talk, and so the story I told myself was that gained trust for them, because we could really, we didn't have to like try to guess what that person looked like behind their mask. That was kind of the thing we all did for a while. Yeah. I've since pivoted, and I just keep telling my clients as they want to come in and see me that my first visit is virtual. And I've stuck with it because there's so, just that whole the questionnaires and the really being able to talk and discuss, and to, we even get up and move and start looking at things. And it's just so powerful that if they do come into the clinic, it's like you said, Sinead, from your clinicians that you work with, that, they've already started solving problems. They're not sitting there waiting for you to do something to help them. They're already, shifting themselves and doing, since we had that talk, I started thinking about this, and I started doing this. And, so it just really does kind of, I think, ignite that self-efficacy for our clients.
Yeah, absolutely.
Trust in themselves.
And you brought up a really good point there, Susan, that I just wanted to punctuate. And maybe this actually translates back to a potential barrier, but around methods of assessment. And so again, this is where those of us who are very, used to using psychometrically sound questionnaires as part of our assessment, as part of our data gathering, it's much easier to pivot, onto a platform where we're not so reliant on having to even do our assessment in person. And I guess that would maybe be another piece of advice, is to kind of highlight that converting onto this platform just might make it a little bit more clear just where there are a few just gaps in your toolbox, right? But those are gaps that are easy to fill. So maybe it means you need a better understanding of how to kind of be able to do a reasonable comprehensive assessment through observation of movement, but also through administration of self-report questionnaires and how much that can tell us. And maybe it also highlights that, if you feel like you need a little bit of a boost in terms of some of your communication skills, around behavior change theory, right? Your motivational interviewing, some of your more cognitive oriented skills, to bring that in. Maybe it will make it a little bit more clear that that is, just something that you have to bolster up a little bit in your toolbox. So I do think there might be some missing skills for people with this mode of care, and maybe they are feeling vulnerable. But I still would flip it and see that as an opportunity that is just highlighted that these are just tools you need to gather to complete your toolbox. Right? The data is clear that this mode of care is actually more effective because it forces us to have to look at the integrated system. We can't sort of rely on compartmentalizing things and really kind of getting stuck down that, biomechanical, road. So I really do see it is our way forward to evolve as a profession.
Amazing. I'm going to just ask you to comment on one more thing, and then we're going to wrap it up for today, knowing that in a couple weeks' time, we're going to have Sinead back for one more session, and it will be an open mic session where any of you can come on. We'll put that on our website, and we'll put it out on social media so you know when and where you can sign up for that. And maybe we can sort of shelve this last part of the discussion for that, Sinead, but just maybe a quick comment on the state of pain neuroscience education in Canada. Susan maybe can comment in the US, but certainly my observation from having trained thousands of pelvic health physios at this point, for sure, that the pain science piece is still very much lacking. And there seems to be a lack of motivation of physiotherapists to really engage in that skill set to put those tools in their toolbox. And I'm trying to, as an instructor and an educator, to figure that piece out a little bit more. I really want to kind of figure out why that is. Do you have any thoughts or comments on that?
Yeah, so the one thing I will say, and this is kind of more again from my academic lens, is that clearly a barrier that's been identified for a number of years is just lack of consistency across even curriculums. So forget even trained physios who are out practicing, but even those coming out getting such different exposure to pain neuroscience education, right? And so what's an exciting step forward for Canada, at least, is that Tim Weidman, who is an academic from Quebec in Canada, together with other leads, Jeff Bostick and Jordan Miller, who I mentioned before, they have started this really powerful project across all of Canada, where every single university that has a physiotherapy program has been engaged, and an individual who is involved in pain science at each university is engaged as a stakeholder. So at McMasters, it's myself and Lisa Carlesso who are the ones involved in this project. But really, we have established common competencies now, so across the board. And, that the idea is, because there has been such a good job engaging, the universities, that really, I think what will happen as soon as this work is published is it will start to get integrated in a consistent way in the curriculums across the board, right? So that's one exciting way forward for all the new PTs coming out. So we have some consistency, everything's evidence-based. I can tell you from our Delphi consensus from across Canada, really, really excellent list of competencies that we came up with as far as assessment, treatment, thinking from a very sort of multidimensional biopsychosocial approach. So that's exciting to come forward. But I mean, that's still probably a couple years out before it's actually integrated, right? Because it's slow.
Yeah.
You know, what we do for, you know, clinicians who are kind of working on the field, I mean, that's a tough one. And I really do hope that questions come through in the open mic session, because I think this is a really important thing for us to discuss. But yeah, I think we need to still talk about it more. I think we still need to recognize that we have moved from pain neuroscience education, talking about the nervous system, and seeing that that actually has evolved more to, you know, pain neuroscience coaching or counseling within the context of, you know, a psychologically informed care approach. Like, I think that needs to be sort of pushed. But yeah, I definitely would love to discourse about this more for sure.
Sounds like a great discussion. I'm looking forward to it. Susan, do you have any comments yet before we wrap up, just on the American sort of status there?
Yeah, the only thing I was going to add on is in the States, I think it's one of the big barriers for people is that I hear all the time is the where they're practicing, the barriers of the practice itself doesn't lend itself. And to me, that's because you haven't tried, would be my answer, rather than to say I have to see so many people, you know, within a certain amount of time. You still have a choice of way that you work with those people. And, you know, and that, so I think we need to, there's a million reasons why we shouldn't do something. We can find that in any aspect of our life, under any circumstance. There's a million reasons why I don't eat that. I don't sleep. I don't, you know, but what do we need to like start to do? Because you got to start somewhere, and you have to start the change somewhere. So I'm very much looking forward to the next time, to the open mic, so that people can bring those thoughts forward. You know, like the idea here is, how do we help people make that first step? You know, what could be the, you know, the number one thing that might resonate with them to create and spark change. Awesome.
Super. Well, thank you so much, Sinead, for taking your time. I know you're really busy, and you managed to kind of squeeze in a conversation with us in the car today, which is why we don't see your beautiful face on the screen, but we really appreciate it. We will come up with a time for the three of us to agree on again. We don't have that yet, but we will put that on our website and out on social media. So by the time you watch this, that will be available. And please sign up for the open mic session with Sinead, so that we can really start to understand some of these challenges a little bit more deeply, and start to really create some real life solutions around how we make changes within our own practice. So thank you so much, Sinead. Thank you, Susan. Have an awesome day, everybody, and we'll chat soon.